Good afternoon, everybody. It's 1 o'clock. Let's begin. Want to welcome everybody to the CDC's Public Health Grand Rounds, those who are watching us here live in person, or many of those who are watching us via internet. I would like especially to acknowledge a group of Georgia State nurses who have come in person here to be with us today. And also acknowledge that our program has worked with a number of colleagues throughout the country, and there are actually some town halls and working groups and viewing sites who will be watching us live as well. Those who are interested can follow on Facebook and Twitter as well. When I was thinking what to say about this group of speakers, I hope some of you have read Tuesdays with Morrie by Mitch Albom. There is a new book that came out actually before this, The 5 People You Meet in Heaven. And I think that the 5 people who will be speaking to you today are really 5 of the coolest people that can actually talk on a topic. And not only that, they're all really VIPs. And I wanted to very much thank all of them for enormous amount of flexibility and tolerance they have shown for the Grand Round preparations. And they are our own director, Dr. Frieden, Janet Wright, who is the executive director of the Million Hearts, Patrick Conway, chief medical officer, CMS, Dr. Tom Farley, commissioner, New York City Department of Health and Mental Hygiene, and Dr. Anthony DeMaria, who is a chair in cardiology, University of California, San Diego. Our first speaker is going to be Dr. Frieden, who is going to make a few opening remarks.
Thank you very much, Tanya, and thanks to our speakers for being here today. This is a critically important topic. Heart disease and stroke will kill 800,000 Americans this year, and yet most of those deaths could be prevented. And the Million Hearts Initiative is an attempt across the federal government and with private entities throughout the country to reach very ambitious but achievable goals. The model we have of factors affecting health is socioeconomic factors, first and foremost, driving health status, changing the context and doing things that can change the default value. So individuals' default decision is the healthier decision, and doing things like making the air smoke-free and eliminating trans fat are examples of this. Long-lasting protective interventions that require only a few brief clinical interventions, classically vaccination. We don't yet have a vaccine against heart disease and stroke, but we do have interventions that work very well to improve risk factors, for example, reducing problem drinking or reducing tobacco use. Clinical interventions which require the clinical care system to work day in, day out around the year, and we're particularly pleased to have a very close collaboration with the Centers for Medicare and Medicaid Services in the implementation of the Million Hearts Initiative. In fact, the 2 entities are the 2 lead entities for this, fittingly because not only do we have community prevention and clinical prevention, but we also have a lot of interventions and interactions between the 2, and counseling and education to encourage people to eat healthy and be physically active. Over the past few decades, we've seen progress. So heart disease deaths have been cut by about half, were cut by about half between 1980 and 2000. And about half of that decrease was from clinical interventions, and the other half of that decrease was from community interventions. That, however, is far from good enough because our rates are still extremely high. We need to look not to our past for what the rate has been in the past, but to the potential of drastically reducing heart disease and stroke rates. And you'll hear about one example of a very ambitious approach in San Diego later in this session. The key components of Million Hearts are in the 2 spheres. First, the clinical sphere to improve the ABCs, control of blood pressure and better management of people with cholesterol, aspirin use, and smoking cessation. And the 3 keys, we think, to improving clinical care, first is focus. And for groups at CDC that have worked on things like immunization or rational use of antibiotics, we know that focusing clinician attention to the most important indicators is crucial to improve outcomes. But it's not enough. We also need information technology so that the clinician has information that they can use and act on to improve their performance. And it's not enough to have focus and information technology. We also need clinical innovation and particularly team-based care to improve the performance of the healthcare system in the service of helping patients live longer and healthier lives. In community prevention, we change the context by reducing tobacco use, reducing sodium consumption, and eliminating artificial trans fat. And we think that with these simple interventions, we can have a very substantial impact and, in fact, prevent 1 million heart attacks and strokes in the next 5 years. How do we do today? Well, despite spending $2.5 trillion a year plus on healthcare each year, less than half of Americans who should get an aspirin, who would benefit from an aspirin without any clinical debate, are on it. Only 46% of Americans with high blood pressure have it adequately controlled. Only a third of those with high cholesterol have it effectively managed, and less than a quarter of smokers who want to quit and go to their health professional to get help get evidence-based assistance to quit. Taking blood pressure as one example, there are 37 million Americans who have their blood pressure out of control. That's more than half of all Americans with high blood pressure. Nearly half of those are in care but not effectively treated, either because of clinical inertia or lack of information systems or lack of adequate access or lack of ability to pay. One reason or another, they're not being effectively treated. Another nearly 40% say, when asked in NHANES, that they're not aware of having high blood pressure. Whether they were told and didn't remember, or weren't told, or it wasn't measured, we don't know, but they are currently unaware of it and therefore untreated as well. And a much smaller number are aware of it but not being treated. So we need to address each of these slices of the pie if we're going to get to the very ambitious goals. For clinicians, we say very simply, if you do one thing for your patients, make it the ABCs, effective care of the ABCs. There are evidence-based ways to prevent heart attacks and strokes, and this is how we can save the most lives and get the most health value out of our healthcare investments. So thanks again to the speakers, and I look forward to the rest of the session.
Thank you, Tom. I'm Janet Wright, Executive Director of Million Hearts. As Dr. Frieden mentioned, Million Hearts is a national initiative with a very explicit goal to prevent 1 million heart attacks and strokes. It is co-led by the Centers for Disease Control and Prevention and Centers for Medicare and Medicaid Services. The clock on this initiative started ticking on January 1st. The goal is audacious, but it is achievable only with the collective efforts of each of us as individuals and as members and leaders of the organizations and the communities and the workplaces where we live. While we've seen a gradual decline in mortality from cardiovascular diseases over the last 40 years, it remains the nation's leading cause of death and disability for women and men and for all races and ethnicities. Each year, 2 million people will have a heart attack or a stroke, and 800,000 of them will die. The trauma to families and to communities and households is devastating. And it's also costly for the economy, $444 billion, more than $1 billion a day, in medical costs and in lost productivity. Cardiovascular disease is also the leading cause of health disparities by race. The evidence tells us that the pathway to preventing 1 million heart attacks and strokes in a 5-year period is through focus on the ABCs. That's the appropriate use of aspirin for those at risk for events, blood pressure control, cholesterol management, and smoking cessation. The good news is that we know what works, and medications, when they're required, are low cost. The less good news, as you just heard from Dr. Frieden, is that we're not hitting even 50% as a population in achieving those evidence-based targets for the ABCs. Million Hearts is working along 2 pathways. We expect them to converge over time. But now the community efforts are to keep the population healthy and to reduce the number of people who actually need treatment. The clinical interventions are to optimize care for those who do need treatment. At the community level, the prime movers are reducing tobacco use and sodium and eliminating trans fats, artificial trans fats, in the food supply. As you know, tobacco is the leading preventable cause of death in the United States. A combination of smoke-free laws, cigarette price increases, access to proven quitting treatments and services, and hard-hitting media campaigns reduces healthcare costs, and it's going to save lives. These comprehensive strategies are not yet being deployed in every community across the U.S. About 90% of us consume more sodium than is recommended for a healthy diet. Most of the sodium we eat comes from processed foods and from foods prepared in restaurants. Gradual and progressive reduction in the sodium content will have the profound effect we're after on the prevalence and the control of hypertension. Artificial trans fats, they're harmful, changing cholesterol patterns for the worse. The IOM recommends reducing trans fats as close to possible to zero. In 2003, the FDA ruling required the labeling of trans fats on foods, and consequently, thereafter, the food industry started to reformulate foods leaving out trans fats. We know that reducing artificial trans fats is feasible. It doesn't affect the cost. It doesn't change the flavor, the texture of food. Our taste buds don't know the difference. Monitoring the trans fat levels in the population and encouraging the food industry to eliminate them is critical. Move on to the clinical arena now. Million Hearts has chosen these three priority areas, I think, as Dr. Frieden mentioned. First, we want to draw the attention of the healthcare professionals and the systems in which they work to the ABCs. Second, we want health information technology to work magic for busy practitioners and the patients they care for. And finally, we want to develop and test new models of care that recognize and reward outcomes and value. So Million Hearts' work in clinical prevention is to develop a simple, uniform measure set for the ABCs and to ensure that the data that's used to calculate those measures moves seamlessly within the flow of care, minimizing the administrative burden of collecting and reporting on those measures. High performance on these measures should be linked to recognition and to reward for clinicians, for the health systems, and for their patients. Currently, we're tracking some 47 interventions across the federal family that include and reward performance on one or more of the ABCs. These interventions could range from an action that takes place in a physician's office to a program in the community and to a policy. Our second strategy is to fully deploy health information technology. Clinicians need the registry functionality to be able to identify gaps in care, to intervene, and to track progress of people with high blood pressure or high blood lipids. Point-of-care risk assessment tools ensure that the interventions are designed and targeted to the individuals most likely to benefit. Clinical decision support that is specific to the patient ensures that the right care is delivered the first time and every single time. And for those of us who take medications and need a little help adopting and sticking to new health habits, HIT can provide the nudges that we need to get and to stay healthy. We live in a historic time. It's when new care delivery models are being developed and launched. Million Hearts is working to embed the ABCs in these new models and to recognize and reward value over volume and outcomes over processes. These new models recognize the contributions of a wide variety of team members, pharmacists, cardiac rehab teams, health coaches, community health workers, peer wellness specialists are all among behavior change agents, very powerful agents that can support healthy behaviors and also advise in the appropriate use of medications. So let's look to the future, where the clinical and the community worlds converge. In this new world, and we want it not to be very long from now, we will have lots of lower sodium foods from which to choose. Our taste buds actually prefer them, and our wallets don't suffer as a result. Blood pressure cuffs are everywhere, and the readouts are simplified in red, yellow, and green, along with numbers for those who want them. A person can designate that readings are automatically sent to a professional, so advice and, if necessary, dose titration can be easily accomplished. Access to medications is no longer an obstacle to control. This is not a fantasy. In fact, studies have shown that adding web-based pharmacy care to home blood pressure monitoring increased the percentage of control by over 50%, and in high-risk folks. So here's the nation's current population-wide performance on the ABCs under the column marked baseline. Under target is our goal for the population by January 1st of 2017. The numbers under the clinical target column reflect the goals within systems of care, folks who are already in systems of care, and are held to a higher standard. These are the audacious goals that will prevent 1 million heart attacks and strokes by 2017, a goal that requires focused attention by all of us. We all have a piece to play in achieving the 1 million hearts goal and creating a new future of cardiovascular health in the country. Our next speakers will describe how these groups are building the new future. Every agency on this slide is deeply engaged in substantive work to prevent heart attacks and strokes. We're delighted to have a wide array of private partners as well, including medical professional societies, retailers, health plans, community programs, and consumer groups, with more coming in every day. So I ask, what will each of you do? I encourage you to visit the Million Hearts website, pledge your support, and encourage others to do the same. If you're hosting a viewing party today, please write us at millionhearts@hhs.gov to tell us about it, and post your photos to our Facebook page. The conversations are going to keep on going on Facebook and Twitter. We ask you to join us. It's now my pleasure to introduce my esteemed colleague, Dr. Patrick Conway.
Thank you. I'm Dr. Patrick Conway. I'm the CMS Chief Medical Officer and Director of the Office of Clinical Standards and Quality. CMS is very excited to partner with the Centers for Disease Control and Prevention on the Million Hearts Initiative, other agencies, and the community to achieve our Million Hearts goal. Today, I will briefly discuss CMS's overall purpose in today's healthcare society, CMS's role in Million Hearts, and build off the clinical preventions you heard from Dr. Janet Wright. CMS is the largest purchaser of healthcare in the world and provides healthcare coverage to approximately 150 million beneficiaries through Medicare, Medicaid, and the Children's Health Insurance Program. Medicare alone pays out over $1.5 billion in benefit payments per day. Combined, Medicare and Medicaid pay 1/3 of the national health expenditure, and only a small proportion is currently focused on prevention, although we want to increase our focus on health transformation and prevention. This is why a program like Million Hearts is so important. Millions of consumers will receive health care coverage through the new healthcare exchanges authorized by the Affordable Care Act and led out of CMS. CMS's aim is to provide better health for the population, better care for individuals, and lower costs through improvement. You can see that our aim ties directly to the goals of Million Hearts. CMS has partnered with CDC, the Office of the National Coordinator for Health Information Technology, the Health Resources and Service Administration, communities, and many, many more. We have convened meetings to identify agency-wide standard Million Heart measure sets for 2012, working collaboratively with the CDC. One of our specific contributions is the development of the first measure that is monitored entirely via electronic health records on risk-stratified cholesterol screening and control. It utilizes risk factor information for coronary heart disease to determine the appropriate LDL level for each patient. Many of our offices, including my own Office of Clinical Standards and Quality, are supporting Million Hearts through a number of programs and initiatives. In the next few slides, I will highlight a few offices' programs that are supporting Million Hearts and CMS. In a later slide, you'll see greater detail about the work of the quality improvement organizations around the country. CMS's Center for Medicaid, CHIP, and State Services are working on Medicaid smoking cessation and Medicaid incentives to prevent chronic disease. Through programs like Million Hearts and these initiatives, we can now assure that smokers in the Medicaid system will have access to smoking cessation services. We are including the ABCs in the essential health benefits and insurance exchanges. Through the Innovation Center, we're launching the Care Innovations Exchange. We received an abundance of applications for the $1 billion of initial funding that we'll be putting out to improve the health care in the U.S. We look forward to seeing the impact that these grants will have on our communities, such as increasing the use of registries, shared decision support tools, and improving population health. For the rest of my speaking time, I'll discuss CMS's efforts in clinical prevention to optimize care for those who need it. The measures for the ABCs have been identified, and more detail can be seen at this website. There are several measures that will be used. There's enormous value in having aligned measures that cover the ABCs for many providers and across major health initiatives. We need measures to set goals, monitor our progress, and drive large-scale improvement. CMS was instrumental in selecting the measures for Million Hearts with CDC, such as the National Quality Forum Measure 18 for blood pressure control, and proposing these measures for inclusion in the Physician Quality Reporting System, or PQRS, and other programs in hospitals and outpatient settings through rulemaking and comment. Electronic health records can improve the quality, safety, and efficiency of clinical care. CMS and ONC are working together to incentivize the implementation of certified EHR technology that requires providers to submit data on clinical quality measures and includes a number of proven features, such as patient registries and computerized prescriptions. CMS has included the Million Hearts ABCs as part of the clinical measure reporting requirements, which will allow us to monitor the quality of care provided to patients with cardiovascular disease. We are also looking at these as core measure requirements. These EHR efforts will reduce redundancies, enable better care coordination, and improve population health, all in a protected and secure fashion. One powerful requirement in the electronic health record incentive program is the use of clinical decision support tools. These tools make use of specific clinical information that is entered during a patient visit and provide real-time recommendations that support clinical decision-making. Examples includes alerts for high blood pressure or high cholesterol values, and then guideline-based prompts to the clinician to act on those values. These are efforts that are going on as part of the Million Hearts to develop evidence and guidelines-based clinical decision support tools that support the ABCs. We look for more work in this area in the future. Now let's talk about launching new models of innovations in care delivery. Through PQRS and working with clinicians, we are measuring and encouraging improvement in measures such as tobacco use, screening and cessation intervention, and hypertension blood pressure measurement. This includes a focus on medication adherence and medication reconciliation. Providers may earn an incentive payment for reporting. As a reminder, clinical prevention strategies will focus on improving the quality of care, access to care, and outcomes. We are launching models of care delivery through the Innovation Center and payment programs such as bundling and accountable care organizations to foster team-based care, coordination, and patient-centered care, including care outside of the traditional office visit. Through the QIO program, we're launching learning and action networks and collaborative improvement models. These are drivers of quality and improvement and collaborative learning. The quality improvement organizations run and will convene an innovative learning and action network locally in every state they serve. It may be accomplished through in-person meetings, WebExes, phone conferences, and other modalities. The QIOs work directly with Medicare beneficiaries and providers. We just recruited the Learning and Action Network mechanism, and we look forward to reporting on this collaborative improvement model. This is really a new phase in the QIO program. CMS calls upon QIOs to serve as the boots on the ground in the important role of being conveners, organizers, motivators, and change agents by providing a call to action through outreach, education, and social marketing, serving as a trusted partner in improvement with beneficiaries, healthcare providers, and stakeholders. Many of these roles can be fulfilled through facilitation and execution of the following three drivers of quality. First, supporting and convening learning and action networks. Second, providing technical assistance, including quality improvement expertise, feedback and data, and supporting clinicians. Third, partnering with beneficiaries and providers to improve care and achieve better health at a lower cost. We are looking at additional ideas such as testing changes to medication copays or allowing nurses and pharmacists to titrate medications to achieve blood pressure goals. We've already in the hospital setting lowered regulatory burden so people can practice to the full extent in a proposed rule and are working on finalizing that rule. This all boils down to communication, support, and partnerships, everyone working together to achieve the Million Hearts goal of preventing 1 million heart attacks and strokes. It is critical that we work together as partners. Some ways that Million Hearts team can help are support existing and already released interventions, improve the effectiveness of these interventions, propose new interventions that CMS should work on, align existing CMS interventions across the federal family, and include Million Hearts and ABCs in outreach and communications. As a practicing clinician, I can't tell you how proud I'm here to be working with the CDC, and on behalf of CMS, we really value our partnership and our ability to transform care in the U.S. Thank you, and I'll welcome Dr. Thomas Farley.
Good afternoon. I'm Tom Farley, the Commissioner of the New York City Department of Health and Mental Hygiene, and happy Mardi Gras. I'll be describing initiatives undertaken by the New York City Health Department since 2002 to reduce cardiovascular disease. I'll be including our environmental initiatives, specifically smoking prevention, trans fat restriction and sodium reduction, and our clinical initiatives focusing on a prevention-oriented electronic health record associated with quality improvement technical assistance. First, our smoking program. The key policy change in our smoking program has been the smoke-free air policies. In 2002, New York City passed the Smoke-Free Air Act, which prohibited smoking in indoor workplaces, including restaurants and bars. In 2011, this was extended to outdoor parks and beaches. Then in this year, 2012, the City University of New York, an extensive university system, will make all of its 23 campuses in the city completely tobacco-free. Another important policy change has been the increase in cigarette prices through tax increases. In 2002, the city passed a tax increase of $1.50 per pack, bringing the total tax on a pack of cigarettes in 2002 to over $3. Additional state and federal tax increases that occurred between 2002 and 2010 brought the total tax on a pack of cigarettes to $6.86. A pack of cigarettes in New York City now costs about $11, which is the highest price in the nation. We've also extensively used mass media for smoking prevention in New York City. We developed many of our own messages, in which we keep fresh by providing new information or developing new ways of presenting old information, and in some cases by using testimonials. All of our messages are tested in focus groups of smokers, and we place them on television and on subways. Once a year, we link a new campaign with the distribution of free nicotine patches and gums. This is an example of a recent campaign. It emphasizes the suffering that smokers will endure rather than death, which we found that smokers don't fear very much. This particular campaign has an emphasis on emphysema and stroke. And it introduces a new idea, the potential that family members may have to provide care for smokers, which is something which we found is particularly disturbing to smokers. So I'm going to see if I can show you this, one of these ads. As you can see, we find no virtue in subtlety. So what's been the effect of our smoking prevention program? This slide shows trends in smoking prevalence in New York City from 1993 to 2010. Before 2002, for about a decade, the smoking prevalence in New York City was steady at about 21%. Since then, the prevalence has fallen by more than a third to 14%. This now represents 450,000 fewer smokers in New York City. Next, our emphasis on trans fat. We restricted the use of trans fat based upon the rationale that trans fat is an artificial chemical that increases heart disease risk. A 4-gram consumption of trans fat, or the typical amount that you would get in a portion of French fries, increases heart disease risk by about 23%. In 2006, the New York City Board of Health voted to prohibit the use of trans fats by restaurants. In 2007, the Health Department began enforcing this prohibition by issuing violation fines during restaurant inspections. By 2008, more than 90% of restaurants were in compliance. This idea has now spread to other cities. This slide shows other cities and states that have enacted or considered trans fat restrictions since that time. The states or cities that have enacted restrictions are shown in blue, and the states or cities that have considered restrictions are shown in red. Also, following the approval of the New York City Health Code Amendment, more than 50 restaurant chains have announced or reiterated their intention to discontinue the use of artificial trans fats in their foods. New York City has also led a national initiative to reduce the sodium content in food called the National Salt Reduction Initiative, or NSRI. The rationale is that sodium consumption is far too high, and the reduction of 1,200 milligrams per day on average in American consumption could save tens of thousands of lives per year nationally. The goal of this initiative is to reduce the sodium intake by 20% over 5 years. It's a voluntary initiative represented by a government-industry collaboration. Through meetings with food companies, we have classified packaged food into 65 categories and restaurant food in 24 categories. We then set reduction targets for each of the categories for 2012 and 2014, with the average reduction of 25% during this time period. We've then asked food companies to commit to meeting these targets in their sales-weighted averages. So far, 28 companies, representing both packaged food companies and restaurant companies, have committed to meeting at least one of our sodium reduction targets. This includes food giants such as Unilever, Kraft, and Campbell's, and some major restaurant chains, including Subway and Starbucks. Now I'll turn to our clinical initiatives. Our main approach is what we call the Primary Care Information Project. The goal of this project is to improve the quality of care through health information technology. In this project, we have developed with a vendor a prevention-oriented electronic health record and deployed it to more than 3,000 providers serving nearly 3 million patients. Key prevention features of this electronic health record include a clinical decision support system, which gives alerts to providers about the services that are needed, that are actionable. That is, that they lead to specific responses of the providers, and the ability to generate condition-specific lists of patients in need of specific care, such as blood pressure control. In addition, the providers get quality dashboards they can use to track their performance and compare them to their peers. An example of a quality dashboard is shown here. Trends in performance on the percent of patients with hypertension whose blood pressure is controlled is shown here compared to their peer providers in gray. And the percent of patients whose smoking status is assessed over time is shown here. In this case, it's compared to the meaningful use target in green. The dashboard also presents automatic recommendations, in this case, improving the percent of patients who have A1C testing. The providers receive these dashboards via email with a link to the health department's provider website, which has information on all of the measures included in the dashboards. We're tracking the information for clinical prevention services across all of our PCIP providers, and the trends are very positive. We've seen, as you can see here, increases over time in the percent of eligible patients receiving aspirin, the percent of patients with hypertension whose blood pressure is controlled, and the percent of smokers who are receiving a smoking cessation intervention. So what has the impact of all these actions been on cardiovascular disease? Well, during this time period, we've seen substantial decreases in mortality from cardiovascular disease in New York City, including a 33% decrease in ischemic heart disease mortality and a 16% decrease in cerebrovascular disease mortality. Now, I can't say the degree to which our interventions caused this change, but it certainly is encouraging. Over the same time period, life expectancy at birth in New York City has been increasing, and increasing at a rate faster than the U.S. as a whole. By 2009, life expectancy in New York City was 2.4 years higher than it was nationally. Now, this slide shows life expectancy at age 40. Unlike life expectancy at birth, this measure reflects improvements in mortality that occur solely in older adults. In this measure also, New York City is substantially outpacing the United States, especially in the last 5 years. In summary, in New York City, our efforts to address cardiovascular disease are showing signs of success. The interventions we've used share various characteristics of implementation on a mass scale, which is what we need because cardiovascular disease is so common. So let me just finish with the thought that mass diseases such as cardiovascular disease require mass remedies. Thanks very much. And now I'll turn it over to Dr. DiMaria from San Diego.
Thank you very much. It's a pleasure to be here to tell you what we've been doing in San Diego to try to eradicate heart attacks and strokes. There's a number of medical factors that underlie what we're trying to do, and they're well known to you. They've been covered already in the discussions. Cardiovascular disease continues to be the #1 cause of death in our society, and in fact, in San Diego, deaths from heart attack alone account for nearly 5,000 persons per year. Now, there are a number of risk factors that predispose to cardiovascular disease. You've heard about them already. And in fact, there are several therapies that have been documented to be effective in reducing heart attacks. I often think of what Ken Cooper used to say: everyone's got to die of something, but there's no sense of dying something stupid. And in fact, if we know that there are risk factors that we can reduce, and we have methods to reduce them, it seemed to us that if we just implemented this strategy in San Diego, that we could in fact reduce, if not totally eliminate, the number of heart attacks. And so our effort in San Diego falls under the umbrella, the overall effort of the San Diego County Health and Human Services Department that has had a long-standing long-standing commitment to improve the health of the citizens of San Diego. That's called Live Well San Diego. San Diego County has been, we believe, uniquely effective in translating federal initiatives into local action. And we've been fortunate enough to acquire a couple of grants to help us in this regard, two of them funded by the CDC, the Communities Putting Prevention to Work grant, which is particularly focused on reducing chronic diseases by increasing hygienic lifestyles with physical activities, nutrition, and working in the schools. And the Community Transformation Grant, also funded by CDC, focused upon making San Diego tobacco-free and reducing hypertension and cholesterol levels. San Diego's also been blessed with the Beacon Grant, Health Information Grant, and the Beacon Grant is an award given to communities to initiate health information technology to improve the quality of health care. So how did we get started in this? Well, it actually started as part of the Right Care Initiative, which was an effort launched by the California State Department of Managed Care to improve the performance of healthcare providers and in the process to improve the outcomes of health for people in the state. And San Diego was selected as a demonstration site. And soon this effort was joined not only by managed care, but by medical groups beyond managed care, by the UC Berkeley School of Public Health, and by Rand Health, who had a GO grant that was also focused in San Diego as a demonstration project. And the goal of Right Care was to achieve national HEDIS 90 percentile goals as regards to optimal blood pressure and optimal lipid levels. To do this, we originated something we call the University of Best Practices. The University of Best Practices is a gathering of representatives of virtually every medical organization in San Diego. It's not only physicians, but nurses and administrators and healthcare workers and pharmacists who attend this. And at monthly meetings, we focus on discussing strategies that have been most successful in achieving HEDIS goals. Now, for the first time, we are about to share data between groups, and we feel this is really an enormous step forward. We joke that these University of Best Practice meetings are the only place that people can come and leave their guns at the door. These are all competing medical groups, and we get together to enhance the health of San Diegans. Well, the Right Care Initiative soon grew into something we've called the Be There campaign. And in this Be There campaign, we've developed what we think is a really audacious goal of eliminating heart disease and stroke in San Diego, something we have called making San Diego a heart attack and stroke-free zone. Now, what in the world would make us consider such an audacious goal? Well, we thought by going for a goal of making San Diego heart attack and stroke-free, that we would capture the attention of the public. We would cut through the background of health-oriented messages that people are always receiving. We'd extend our program to every citizen of San Diego, and we'd involve them in their their own health care. In fact, our strategy was to convey ownership of this program to the community at large rather than to the doctors and nurses. And we wanted to exploit the community arrogance of San Diegans who believe they live in the very best place in the world and they are uniquely blessed, and to exploit that arrogance to get everybody to work together to reduce heart attacks and strokes. And our program was aimed at activating patients to become screened, and then enlisting and recruiting physicians to implement the optimal medical care and to ensure compliance over a long period of time. We were fortunate enough to gather funding, philanthropic funding from Jack and Judy White for $650,000, and we formed a committee between the private sector and between government, especially San Diego County, to move forward in this project. Now, we understood from the beginning that facts alone are not often enough to get people to change behavior, that to be most effective in changing behavior, you need an emotional touch. And so we were focused on a saying by Robert Brault some time ago: when something is missing in your life, it usually turns out to be someone. And so we felt that we would be more effective in driving change in behavior by appealing to individuals' choice to benefit a loved one than to benefit themselves. And so that doing things for a loved one would be more likely to happen than doing things for yourself. And that generated the Be There campaign. Now, I understand that names are not usually allowed at this meeting, but we've been granted this exception because we think we have an unusual convergence of virtually every healthcare provider in San Diego. As you can see this from this list of our steering committee, we have representatives of UC San Diego, of Scripps, of the American Heart Association, of the Sharp Health Plan. We have representatives of the Naval Hospital and the VA Hospital, the California Chronic Care Coalition, and very importantly, the San Diego Medical Society. Perhaps of greatest importance, we have the full participation of the San Diego County Public Health and Human Services Department. So our Be There campaign is aimed also at exploiting the robust technology industry we have in San Diego. We have a very, very vibrant wireless medical technology, and we plan to join with them in this effort so that our Be There campaign can act as a test tube for the development and evaluation of some of these technologies to enhance patient compliance and even detection. For instance, surveillance of the electrocardiogram through wireless technology, or utilizing pills that after swallowing can emit a signal that can be detected, or various technologies that we might employ in ensuring long-term compliance. Now, we've already begun, and we have a variety of activities that are underway. I've told you about our University of Best Practices, which is our vehicle to enlist physicians. We plan a number of screening events at shopping malls, pharmacies, schools, and especially in the faith-based groups that exist in San Diego. We'll distribute pamphlets, pins, and other types of materials. And in fact, we plan to have an extensive multimedia campaign that will involve all media platforms, and especially the social media platforms that exist. So we've created a patient activation campaign that we plan to be the centerpiece of our effort, that will be the centerpiece of our advertising in the media, in the shopping malls, on buses and whatnot. And I'd like to share a few of those with you. Here you see a grandfather with a grandson teaching his grandson how to surf, very San Diego appropriate. And the saying reads, "His first perfect wave, be there." We also plan to focus very closely upon minorities and underserved. And here you see an African-American father dancing with his daughter at her wedding. And the saying reads, "It's her time to shine. Be there." We intend to get more intense in our messaging as we go along. And here you see a picture of a daughter sitting next to her father whose picture is ghosted out, indicating he's deceased. And the saying reads, "The thing I missed most, Dad, is our heart-to-hearts." And there's a little saying on the father that says, "Every 5 hours, someone in San Diego dies of stroke." The last example here shows a son playing chess with his father who's ghosted out. And the saying reads, "Dad, you never let me win. Now I would do anything to have you beat me just one more time." And the saying on the bottom, "Heart disease kills over 100,000 Californians each year." We hope that these kinds of messages will incentivize people to take care of themselves so that they can be there for loved ones. So, to summarize, we have initiated a call to action to eliminate cardiovascular disease from San Diego. Although we aim for a heart attack and stroke-free zone, a more realistic but still audacious goal would be to reduce heart attacks and stroke by 50% in 5 years. Thus far, the entire medical community has been organized. We've been fortunate to receive philanthropic support. A patient activation campaign is fully developed, and we have a strong integration with San Diego County health programs. We hope that what we're doing in San Diego and the program that we are creating will be one that can be translated to other communities throughout the country and, in fact, throughout the world. Thank you very much for giving me the opportunity to bring you up to date on what we've been doing to eradicate heart disease in San Diego. And now back to Janet.
I want to thank all our speakers and encourage those of you who have questions to go to the microphone at either end and ask your question. And Tony, I spent more than a couple of decades in Northern California. You spent time there too. I just have a tip for you guys in Southern California. That surfboard lesson, it actually works better in the ocean than the beach. So, anyone have a question? I do. While you're thinking of yours, you know, it strikes me that you all, each in your own way, touched on this concept of behavior change, the need for behavior change, individual level, system level. Where I'm going here is to ask your thoughts for the group about the incentives, either the carrots or the sticks that you've seen in your work so far or you're building into your work. How do we shape behavior through incentives?
Well, obviously, the fact we've taken in San Diego for patients, the incentive to get screened, to identify their risk factors and comply with treatment would be to be there for loved ones. For physicians, I think physicians are naturally motivated to be at the top of their list. And so the feedback in how they're performing with regard to goals hopefully will be both an incentive and a motivator.
Just there are two incentives that we're looking at with physicians. One of them is them having the feedback and I guess tied to that clinical decision supports. The second is whether reimbursement actually makes a difference or physicians are motivated enough to improve the quality of care of their patients, whether the financial incentive doesn't make a difference. So we actually have a prospective study going on now, and we don't have the results in yet, but looking at the early data, it looks like we're going to see some element of both, that we can get improvement simply by providing good information at the right time, but there may be some additional benefit with some financial incentives around quality improvement.
So I'll quickly name 4 things. So 1, reporting and feedback. So we think this is critical for clinicians, also informing patients. 2, payment incentives. So we're moving away from a fee-for-service model to a value-based model. 3, and I was remiss not to hit on this more during the talk, I think aligning the public health and the medical care enterprises. So I come from a background of collaborative improvement models, thinking about community and population health. I think the more CMS, CDC, and other can bring that public health and clinical care together, as Dr. Frieden alluded to, is critically important. And then I think the last, which I think basically aligning with professionalism. So I think we have a lot of ability to work with professionals, whether they be public health professionals or clinical professionals, and utilizing that intrinsic motivation for improvement.
Thanks, Patrick. If you'd identify yourself first and then ask your question.
Sure. Bob Brewer in the Chronic Disease Center. I had a question for Dr. Farley. First of all, very impressive series of presentations and very ambitious campaign. I congratulate you about that. But Dr. Farley, I wondered if you could just talk a little bit more about how you built community support within New York City for what is obviously a very impressive series of tax increases around tobacco. I think there was sort of a collective in the room when you said $11 a pack. So talk to us a little bit about that, would you please?
You know, most of the tax increases occurred before I got there, but I will say, so I won't say who had a part in it, but let me say that it got beyond a certain point where legislatures saw that there wasn't that much resistance to raising tobacco taxes, and it was a good source of revenue, so that the last tax increase that occurred in New York State happened without a lot of public health encouragement. They just saw it as a pure revenue move, which is surprising. It's good in many ways. It's not good if that means that they don't also use some of that funding to support tobacco control programs, but I think we've gotten past a certain point now with tobacco tax increases where people realize that the political pushback is limited.
This question is for Dr. Farley as well. I'm Shahid Iqbal from Immunization Safety Office. I was Dr. Farley's student at Tulane, and it's good to see that what he taught us in the classroom has actually been implemented in practice. But I do have one question that I'm a big proponent of structural intervention or changes to policy change or introducing laws. But we see that in New York, a lot of the success that came in the form of policy change, introduction of laws or tax increases. But our national agenda, we focus a lot on education. Do you think we need a shift in our focus, and we should shift our focus more towards structural intervention? And as you've said in the Rose's law of prevention, that focuses on shifting the curve instead of cutting the curve. So what's your take on that?
I do think that policy and environmental change is the best way to reduce rates of disease that are population-wide diseases like cardiovascular disease, and I think we need to look much more at that. Now, I will say this, it's a lot easier at the local level than it is at the state level, and it's easier at the state level and at the national level. My experience is that the pushback or the resistance from industry lobbies are less at the local level than they're at the state or the national level. So we have opportunities in New York City that you simply don't have at the national level, but we certainly want to take all those opportunities and hopefully set examples for the rest of the country, and then it makes it easier for other places to do it.
Dr. Conway or anyone, what do you think we can do to help the healthcare system improve their performance rapidly? Because we know how diverse the payers are, the providers, the challenges of clinical inertia. How do you think we could get as rapid an improvement as possible? Where should we be focusing most attention to see real improvements in heart health?
So So first, aligned incentives, which you're already working on and doing, but I think further that alignment across private payers, across the public health and the medical care system. 2, focus, which you're doing. So focus on high priorities. I used to do external reporting for a large delivery system. It was fairly painful to deliver reporting to 80 different entities who all wanted different things. So I think the focus and alignment go together. Third, I think we haven't fully harnessed these collaborative improvement models. So I applaud these efforts like Million Hearts that are really thinking about how do we, in an innovative partnership collaborative model, drive improvement, set goals that are aligned and measures that are aligned, but then allow localities, states, et cetera, to innovate to achieve those goals.
Thank you. I'm going to ask a final question if I don't. Any Envision questions? Nope. I'll warn the speakers. This question is going to be about scalability. I'll give you a chance to think about that as I rattle for a moment more. So we know that there is a chunk of the country that's between San Diego and New York City. And for those of us who live and work there, I'd like for each of you to address either what you think will make it, how your models can get scaled to the rest of the country, or what's in the way of that scalability. Ding, 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 ding.
I guess I go first. Everybody's looking. So I was looking back, but everyone else was looking at me. We had hoped from the very beginning that what we were doing would be applicable to export. And so we tried to design the program that way. I think that there's nothing that we've done in San Diego to this point in time that couldn't be adopted by every other community. The University of Best Practices is a great model for communities to rally around, and there's evidence that a similar group is starting up in Sacramento now that's been in touch with us, and they're not close to the ocean, although not in the Great Flyover. And you know, I think we've been fortunate in terms of philanthropy, but our patient activation campaign, we will share with anyone who wants it. We think it's a good strategy. We think that the material that's been prepared is very effective. So everything we've done is to share with other people for anyone who's interested, and I think all medical communities will be interested.
I just want to address some of the policy changes and their scalability of those. I think we learned in tobacco control that you can be far more innovative and move more quickly at the local level than you can at the national level. So most smoke-free air policies start at the local level. We can apply those same policies to food. Localities can ban trans fats right now. State health departments already regulate restaurants, and so they have ability to do some of the things, have a hand in our food supply right now. And so that those localities shouldn't wait for change at the national level, because just the politics are far more difficult at the national level. So I would encourage them to look at what the best examples are anywhere in the country and pick them up locally.
So I literally think that's the central question of transforming healthcare in America. So but I'll give a short answer. Carolyn Clancy and I wrote a couple papers in JAMA, T3 transformation and transformation at the front line. They're more of a medical care framework, but I think apply more broadly as well. That essentially I think the question is, how do you decrease the cycle time of learning? So how do you test new approaches, rapidly evaluate what works, and then scale that? And I think in this case, it's not easy, or we would have done it before. But I think the central question is that cycle time of learning. I think with the Innovation Center at the CMS level, we're trying to think about how we think about that cycle time in our office and quality improvement. And I would encourage all those in the audience and CDC to work with us on how we really rapidly evaluate programs and scale and spread them, and learn when they don't work in different local contexts. Why don't they work, and why do they need to be modified at a local and a state level? So.
Thank you all for joining us. I'm going to put one last pitch in to go to this website and show your support by taking the pledge.
And I think this was a scientific heaven. So I am asking you to give one more applause to the 5 people you met at CDC. And we'll see you in 4 weeks, same time, same place. Thank you.